Hello and Assalamu alaikum. I'm Hardis from class NHSI 4A, a medical imaging student at the Faculty of Health Sciences UITM Punchakalam. In this video, I will be presenting an overview of the radiographic image evaluation of the hand in the postero-anterior projection. If you find this video useful, feel free to share it as a learning resource for understanding the evaluation of PA hand radiographs. Let's begin. This video has been created for the purpose of knowledge sharing. The topics I will cover include the radiographic anatomy of the PA hand, the essential criteria for accurate positioning, and the necessary exposure factors. Finally, I will explain how to evaluate PA hand radiographs using the Paceman method. Let's begin with radiographic anatomy. A strong understanding of anatomical structures is one of the fundamental skills required to become a competent radiographer. The image shown highlights several key features visible in the hand's postero-anterior projection. As radiographers, we should be able to recognize the phalanges, all the joints, metacarpal bones, and the carpal bones clearly on the radiograph. All right, let's take a look at the anatomy of the hand. The first structure we see is the distal phalanx, which is the final bone located at the tip of each finger. Next, we have the distal interphalangeal joint, which is the joint located between the middle phalanx and the distal phalanx of each finger. Next is the middle phalanx, which is the bone located between the proximal and distal phalanges in each finger, except for the thumb, which does not have a middle phalanx. Then we have the proximal interphalangeal joint, which lies between the proximal and middle phalanges and allows bending of the finger. Moving on, the proximal phalanx is the bone that lies between the PIP joint and the metacarpophalangeal joint. It is the first phalanx of each finger and plays a vital role in finger movement and hand function. Next, we come to the metacarpophalangeal joint. This joint connects the proximal phalanx to the metacarpal bones and allows the fingers to flex, extend, and spread apart. Next are the metacarpals, which are the bones in the middle of your hand. There are 5 metacarpals, 1 for each finger. Each metacarpal consists of a base, shaft, and head. The carpo-metacarpal joints are the joints between the carpal bones and the metacarpal bones. They help connect the wrist to the palm and allow movements like gripping, flexion, extension, and especially thumb rotation. The wrist contains 8 carpal bones, arranged in 2 distinct rows, a proximal row and a distal row. These bones together form the wrist joint and allow a wide range of complex hand and wrist movements. In the distal row, moving from medial to lateral, the carpal bones are the hamate, capitate, trapezoid, and trapezium. In the proximal row of the carpal bones, located closer to the forearm, we find from medial to lateral the pisiform, triquetrum, lunate, and the last one is scaphoid. Next, we will discuss the correct positioning criteria for a postero-anterior hand X-ray. Based on Bontrager and Merrill's atlas, first, the long axis of the hand and wrist must be aligned with the long axis of the image receptor. Second, the shafts of the metacarpals and phalanges of digits 2 through 5 should show equal amounts of soft tissue on each side. Third, digits should be slightly separated so that the soft tissues do not overlap. Fourth, the thumb is in a neutral position, not overextended or flexed, allowing clear visualization without overlap. Fifth, the MCP and interphalangeal IP joints must appear open, indicating the hand is placed flat on the IR. Lastly, the image should include anatomy from the fingertips to the distal radius and ulna. All right, this is an example of an image that meets all the criteria for proper positioning in a PA hand X-ray. Let's go through the key points one by one. 1. The long axis of the hand and wrist is correctly aligned with the long axis of the image receptor. 2. The shafts of the metacarpals and phalanges, especially digits 2 to 5, show equal soft tissue on both sides. This means there's no rotation. 3. The fingers are slightly separated, so the soft tissues don't overlap. 4. The thumb is in a neutral position, not overextended or flexed, allowing clear visualization without overlap. 5. The MCP and interphalangeal joints appear open, showing that the hand was placed flat against the image receptor. 6. The image includes all necessary anatomy, from the tips of the fingers to the distal ends of the radius and ulna. So, this image is a good example of correct PA hand positioning based on standard radiographic criteria. Here is another example. Are all the positioning criteria met? As you can see, the first criterion is not fulfilled. The hand and wrist are rotated or misaligned, which may lead to distortion and affect image accuracy. To correct this, the patient should be asked to reposition their hand so that the hand, wrist, and forearm are aligned in a straight line with the center of the image receptor. Proper alignment ensures a high-quality diagnostic image and minimizes distortion. How about this image? Does it meet all the positioning criteria? As you can see, the second criterion is not fulfilled. The hand appears overextended, causing the shafts of the metacarpals and phalanges, especially digits 2 to 5, not to show equal amounts of soft tissue on each side. Additionally, the MCP, PIP, and DIP joints may not appear open, making it difficult to evaluate joint spaces and overall alignment properly. To correct this, the patient should be asked to relax and reposition the hand so that it lies flat on the image receptor, reducing extension and rotation. In this image, neither the third nor the fifth positioning criteria are properly achieved. The thumbs are positioned too close together, causing the soft tissues between them to overlap. This can make it difficult to detect minor fractures or soft tissue abnormalities. Additionally, the MCP and interphalangeal joints are not well visualized, indicating that the hand was not completely flat on the image receptor. This results in closed joint spaces and potential distortion of the finger lengths. To improve the image, the patient should be instructed to slightly spread their fingers to reduce overlap and ensure the entire hand is placed flat against the image receptor. This will help open the joint spaces and produce a clearer, more accurate radiograph. Now let's examine this image. Does it meet all the positioning criteria? In this image, the fourth positioning criterion is not met. The thumb is overly extended, which has affected the overall positioning of the hand. As a result, the central ray is no longer properly aligned with the third metacarpophalangeal joint, the correct centering point for a PA hand projection. Incorrect centering can lead to uneven exposure and poor visualization of key anatomical landmarks. To correct this, the thumb should be placed in a neutral, relaxed position to maintain proper hand alignment, and the central ray should be repositioned to the third MCP joint to ensure accurate imaging. Here's another example. Looks good at first glance, right? However, in this image, the sixth positioning criterion is not met. The radiograph does not capture the entire hand. Parts of the distal radius and ulna are missing from the image. When key anatomical areas are excluded, it reduces the diagnostic value and increases the risk of missing fractures or other abnormalities. To correct this, the hand should be properly repositioned and the collimation field adjusted to include the full anatomy, from the fingertips to the distal ends of the radius and ulna. Next, let's discuss the criteria for determining an adequate exposure factor. Based on Bontrager's 10th edition, the standard technical factors include
KVP between 50 to 60.
millan hours approximately 2 to 3 for film screen systems. These values are chosen carefully to balance image quality and patient safety. Here are the reasons why. 1. High contrast through the photoelectric effect. At 50 to 60 kVp, the photoelectric effect is dominant. This enhances the visibility of fine bone details, such as the cortical and trabecular structures, which are essential for accurate diagnosis. 2. Minimized scatter radiation. Lower kVp reduces the amount of scatter produced. This helps to avoid image fog and improves the overall contrast and clarity of the radiograph. 3. Sufficient penetration for thin anatomy. Since the hand is relatively thin, a lower energy beam is enough to penetrate and clearly show the carpals, metacarpals, and phalanges, without overexposing the image or losing detail. 4. Optimal image with minimal radiation dose. Pairing low kVp with 2 to 3 millan hours ensures enough radiation reaches the detector while keeping the patient dose low. No grid is required, and using a 100 centimeter SID helps maintain sharp image detail and reduce skin dose. As a general rule for all radiographic images, beam penetration, contrast, and density should be optimal to demonstrate the structure of interest. For the PA projection of the hand, correct exposure and beam penetration are indicated by appropriate radiographic contrast. This can be assessed by evaluating the visibility of the bony cortical outline of thin structures, such as the distal phalanges, as well as thicker structures, like the distal radius or carpals. In addition, the MAs, which contributes to optimal radiographic density and image detail, can be assessed by observing the visibility of the bony trabecular patterns. Clear visualization of trabecula in both thin structure and thick structure serves as evidence of correct exposure technique. With the advancement of digital imaging systems, problems related to overpenetration or overexposure have become less common. However, underpenetrated or underexposed images still frequently occur. Therefore, it remains essential to carefully assess the visibility of the bony cortical outlines and trabecular patterns in both thin and thick structures, as previously mentioned, to ensure that the exposure factors used are appropriate. We have reached the final component of the learning outline. Let's now discuss the image evaluation of a PA hand projection using the Paceman method. Let's now move on to evaluating a radiographic image using the Paceman method. This method provides a structured and systematic approach to assess the quality of a radiograph and determine its diagnostic acceptability. The first component, P, stands for projection and positioning. This is a radiographic image of the hand in a postero-anterior projection. We can identify this as a hand radiograph because it includes all the essential anatomical structures, from the distal phalanges to the distal ends of the radius and ulna. It is confirmed as a PA projection because the long axis of the hand and wrist is properly aligned with the image receptor, and there is equal soft tissue visible on both sides of phalanges 2 through 5, indicating no rotation. Regarding positioning, this image demonstrates correct alignment. The metacarpophalangeal MCP and interphalangeal IP joints appear open, which suggests the hand was placed flat on the image receptor. Additionally, the thumb is positioned neutrally, not overextended or flexed, allowing clear visualization without overlapping adjacent structures. Now, let's talk about alignment. There are 3 key components to consider when evaluating alignment in a radiographic image: the alignment between the X-ray beam and the image receptor, the alignment between the X-ray beam and the patient, and the alignment between the image receptor and the patient. In this PA hand radiograph, the alignment between the X-ray beam and the image receptor, as well as between the X-ray beam and the patient, cannot be accurately assessed due to the absence of visible collimation borders. However, the alignment between the image receptor and the patient appears to be correct, as the distance from the central anatomical structure to the edges of the image receptor is equal both superior, inferiorly, and laterally. The centering point in this image cannot be clearly confirmed for the same reason. No four borders collimation is visible. As a reminder, the standard centering point for a PA hand projection is at the head of the third metacarpal. Let's move on to the next element of PACEMAN, which is C for collimation. In a PA hand X-ray, collimation should be visible on all four borders of the image receptor and must include all relevant anatomy. This extends from the tips of the distal phalanges at the superior border to the distal ends of the radius and ulna at the inferior border, while also including the soft tissue margins laterally. In this radiograph, there is no evidence of a radiation protection device or lead shielding apparatus visible on the image. Next, let's talk about the E element, which stands for exposure factor. The KVP used for this PA hand radiograph appears to be adequate, as there is sufficient penetration and good radiographic contrast. This is evident from the clear visibility of the bony cortical outlines in both the thin structures, such as the distal phalanges, and the thicker structures, like the distal radius and carpals. The MAS also appears to be appropriate, as the overall radiographic density is sufficient and the bony trabecular patterns are seen in both thin and thick structures. This indicates that an adequate number of X-ray photons reach the image receptor to produce a diagnostic quality image. Therefore, no changes to the KVP or MAS are necessary, as both the contrast and density are acceptable for accurate image interpretation. Now, let's move on to the M element, which stands for marker. In this PA hand image, a lead anatomical marker is present. It is correctly positioned on the superior border toward the left side of the image. The marker does not overlap any region of interest and is appropriately placed, meeting standard radiographic requirements. The A element in PACEMAN refers to the aesthetic value of the image. For this PA hand radiograph, the image receptor size used is 24 cm by 30 cm in portrait orientation, which is appropriate and sufficient to include all relevant anatomical structures. The image appears sharp, well-centered, and there is no evidence of any artifacts present on the radiograph. We are now reaching the final element of the PACEMAN method, which is N for name. In this PA hand radiograph, the patient's name, identification, date of examination, and place of examination are all clearly displayed. These details are properly positioned in a suitable area of the image and do not overlap any region of anatomical interest, fulfilling standard radiographic documentation requirements. After completing the evaluation from P to N using the PACEMAN method, it's now time to determine the diagnostic acceptability of this PA hand image. Based on the evaluation, this radiograph is considered acceptable. The image demonstrates correct projection and positioning, appropriate exposure factors, proper collimation, visible anatomical markers, and includes all necessary patient identification details. No repeat examination is required. Great, we've successfully evaluated this PA hand image using the PACEMAN method. I hope this video has helped guide you in evaluating radiographic images effectively. That's all from me for today. Thank you for watching, and I look forward to seeing you in the next video. Bye.